Zamira, can you hear me?
My camera is on.
Oh, you're on. I'm sorry. You're on here twice, Zamira. I'm sorry.
Oh, I'm like, I know I'm not crazy.
No,
Oh,
you're
it
not
must be my
crazy.
other
You're on
laptop. It
here
wasn't
twice.
working. I thought I
Nope.
logged it off.
Okay, nope. You're on here twice. That's why I was like, what?
I'm like,
Okay.
I'm on here.
Somebody just dropped off. Who just dropped
I'm
off?
about to try to. Oh yeah, I am on here. Sorry.
Sorry, I just saw the blank screen, didn't even think. Okay, I apologize. My fault. All right. Can I see everybody? I can. All right, so everybody is here. Right, there are 16 and, or is there 17? Wait, we are still missing one person. I don't know. All right, I'm gonna tell me if you're here, Shahada.
Here.
There you go. Jaquan is here. DeWitt.
Here,
All right. LaShawn.
Here.
Dominique.
Here.
All right. Is it Jimalatu? I know I said that right. Oh, it is. Okay, I saw you shake your head. Awesome. Natasha. Natasha, are you here?
I'm here.
Okay. Um, let's see. Danelle. I know I saw you earlier. Is that who fell off?
where?
Okay, sorry. Let's see. Zamira, you're still on. Zamira's still on. Savannah is still. Savannah, yep, you're still here. Amira. All right. Ramella.
Here.
Ramella. Okay. And then Linda. Where are you? Is that who just popped off? Okay, that's who you just okay, somebody just dropped. Okay. And then Janika, no, saw you, and then Ashley. So I'm not sure what happened to Linda because she was on. Oh, I can't even see. All right. Um, so again, welcome. Week two. We're gonna do our exam reviews next week. So what I have written down is get my glasses real quick. Um, we're gonna do it Friday morning at 10 a.m. And then I'm also going to do one on Saturday at 9 a.m. Does that fit for everybody's schedule?
Yes.
Okay, so that'll cover, we got two different reviews. And hopefully everybody can attend. I will post a review. So once the review has occurred, it will be recorded. I will post them in the announcements. Um, I also have previous course exam reviews. So I'll post the link, the YouTube videos for those as well, so that you can watch multiple reviews if you choose to. Um, and then Dr. Tenza usually will do a Kahoots or post a video. Even though this is the only section, she's still the course lead for this course. So sometimes she will go in and post like a Kahoots recording or excuse me, something along those lines so that you guys have it. All right, so let's go ahead and get ready. We'll take our quiz first. It is 10 questions. You have 15 minutes to take your quiz. The quiz password is butterfly with a capital B. Um, and I will put the quiz password in the chat. So it is capital Butterfly. Again, you have 15 minutes. So it's 2:06. That brings us to, let's just say 5, 10, 15 or so. Let's see, 10, 15, 20. Let's just start class at 2:30 after your quiz. You may turn your cameras off when your quiz is complete and just be back at 2:30. All right, so we have three chapters to do tonight. Um, or tonight, today. I don't know why I said tonight. We're going to talk about chapters 8, chapters 9, and chapters 14. So chapter 8 is all about effective communication, and then chapter 9 is assertiveness, and then chapter 10 is cultural unique. I'm not 10, sorry. Let me skip chapter 10. 14 is all about the interdisciplinary healthcare team. Um, so we'll start with effective communication. So how did you like the excerpt that was in your discussion this week? The excerpt from Everybody Loves Raymond. Has anybody watched that show before? Yeah. It's a pretty good show. I've not watched it like consistently, but um I have watched like parts of it. And think it's a pretty good show. Did you like the excerpt? All right. So I will share my screen. Um, we're going to try to do this without the tears and the eyes watering too bad. Hopefully my voice doesn't go too. So we look at communication. All right. Um, we have one-way versus two-way communication. All right. And so one-way communication gives a command. And a lot of times I'm prior military, right? So this would, basically somebody is telling you what to do, right? Go sweep the floor, go mop the floor. Um, with a one-way communication, there really isn't an expectation of a response, right? With two-way communication, it's a little bit different. That's the usual form of communication that we use in conversation. Each person, equally contributes to the conversation and feedback is expected. It's respected, right? So it's like when I asked you, has anybody watched Everybody Loves Raymond, right? Just that is, an expectation that um, somebody, would provide some feedback. So there's essential components of the communication process. And the five essential components are the source, the sender, right? The message, the method of transmission, the receiver, and feedback, right? And all five of these components are necessary for effective communication, right? So if you're asking a question or having a normal conversation with, friends, coworker, family, right? It's usually, you may ask a question, they, give you some feedback. Um, the method of transportation, the method of transmission, in this case, it's verbal. Um, and then, of course, the receiver is who is, on the other end of the conversation. And it could be an email conversation as well, right? It's not always an in-person conversation. Things that affect communication. So personal characteristics of both the sender and the receiver. Okay, so think of age, gender, income, life experiences, right? Attitudes, opinions, biases. Those are all personal characteristics, right? We don't talk the same way to children, right? That we do to adults for the most part, right? We use our language, our tone may be a little bit different. Um, for girls, if you're hanging out with your friends, right, you're going to talk differently to your girlfriends, right? Guys, same way, then we would talk to maybe members of the opposite sex. Um, Income can also play a big part of this, and life experiences. So, looking at cultural characteristics, and this is really something that we need to pay attention to, especially in healthcare, because we will be working with members of other cultures, religions, races, and there are cultural characteristics that affect communication. So, personal space, right? Um, some. cultures are more touchy-feely, right? Other cultures are more, standoffish. They want a little bit more space. Some are also more, what's the word I'm looking for? Easygoing, relaxed. They want to build a relationship rather than just have a nice formal conversation. What do we do if we are working with a client that doesn't speak our language? What do we do in those situations?
Get an interpreter.
Get an interpreter. Absolutely. And why do we prefer to use interpreters versus a family member?
To make sure what's being said is being repeated correctly and not nothing that they might just want to tell the other family member.
Right, to make sure that what is being said is being communicated appropriately, because there can be bias in that conversation as well. And then you never know, does that person that that family member, friend, that you're using as an interpreter, do they really understand what you're saying, right? Do they understand what is really going on? And so we don't always know if that, information is being communicated appropriately. Situational influences, okay? So these can be a variety of things. I mean, this can be just noise, right? I know you guys have done some clinicals in a long-term care facility. Have you ever walked into a client's room and the TV's at like 1,000 and you're like, I know you can't hear me because I can't hear you over your over your television. Um, or even in, like a nice um, so one thing that I noticed, more so here than in Virginia, the when I was working in long-term care, the nurses station is in the center of the facility, and it's kind of weird. So the nurses station is in the center of the facility, and then the units kind of like go out in a star pattern, okay? And so imagine that, and the tall ceilings, and you've got friends and family and coworkers and residents and everybody's talking. And so the noise level can be extremely overwhelming. And imagine trying to have a conversation, even if it's to a fellow nurse or a coworker. Um, Physical and emotional state. Think of if patients are in extreme pain or if they are having severe or any kind of anxiety that's going to interact or affect, sorry, their communication and the ability to listen and understand what we are trying to tell them. Temperature, odors is a big one, and even distractions. So you're in a client's room and you're talking with them, having a conversation, and, other staff members are coming in and interrupting you, or, you hear things on the overhead or the loudspeaker, the intercom, whatever you want to call it. And so distractions often are, a big part of, and or a big influence in how we communicate. And then context, okay? The background, the circumstances leading to the conversation, okay? And so I mean context, are you going in to give good news, bad news, have a good conversation, have a not so good conversation? Um, you know, these are, how, the just the circumstances, why we're having that conversation. And then we have our types of communication. And verbal is everybody understands verbal communication, right? That's our spoken or written. In some cases, if you're sending an email, writing a letter, charting in your charts, right? That would be considered verbal communication. And then we have our nonverbal communication, and that's our body language. All right. We know how powerful the spoken word is, right? Once you say something, once you write something to somebody, that's there forever, right? You can't ever take that back. And so we make sure that we always speak clearly, that we use proper grammar. Slang generally is not appropriate, especially when we're talking with clients, just because it may have different meanings to different people. I always think of age, okay? I'm a little bit older, okay? So sometimes some of the slang, I don't understand it when I get it from some of the, sometimes younger students or even younger clients. And I'm like, okay, you're going to have to explain what that means because I honestly don't know. Um, and, also, being mindful when we're talking with clients. We teach you a lot of big words in nursing school, right? We teach a lot of big words. And then we're going to tell you once you graduate, don't use big words around your clients, right? You want to try to speak as normal as possible, avoiding those big words, only because generally speaking, unless they have some sort of healthcare background or have done a whole lot of extensive research, right? They may not understand the terms that you are explaining to them. So we try to use just normal everyday verbiage. Um, Maintain your boundaries, okay? Even if, if you're gonna touch someone or, is it okay if I put my hand on your shoulder or, something along those lines? Have you ever, this is always one thing. Has anybody ever had a situation where they're in a conversation with somebody and the person wants to be like right here in your face? And how does that make you feel? Right? It's okay if it's your spouse, your partner, right? That's a little maybe even sometimes your kids, because kids don't always understand personal boundaries, right? Um, I had to make, this was years ago, but I had to make a doctor's appointment. I think I had strep throat. Um, and my doctor that I normally see, she was full that day, so I couldn't see her. So I had to see another provider. And this other provider was really nice. I'm not saying that she wasn't, but she was like right in my face, and I kept trying to like back up, like you're a little bit too close. Um, and so, sometimes, even space could be something that we, need to respect when we're working with people. Nonverbal communication, on the other hand, that's our body language, right? So we have to really be careful. So this could be, the expressions on your face. It could be the eye contact. It could be posture, gestures. It also could be how well are you paying attention to your clients? So let's say I was giving this lecture and I'm like this. Does this show that I'm interested in anything that you guys have to say to me? No, right? Like if you guys were talking to me and I'm playing on my phone, would that show you that I have an interest in something that you are saying? Um, or what if you guys were, asking me questions and I'm just sitting here like this, right? What does this show you? What does this show you? If I'm just sitting here like,
Uninterested.
Not
great,
interested.
I'm not interested, right? I don't want to hear your opinions. I don't want to hear your thoughts, right? I'm just going to sit here and I'm just going to talk and, really don't want to hear anything that you have to say. So we have to be mindful, right, of how we approach. I personally, and this is something that I've had to work on. I am a big hands in my pockets person. Okay. And scrubs have lots of pockets. So, right, you can put your hands pretty much in a lot of different pockets. And I did never realize that that could be a standoffish thing as well, right? So when you're in, you want to try to have an open posture, right? You want your hands to be free, your hands to be seen, um, and avoid, and I think I might have said this in week one, I'm not sure. I am a huge hand talker, a huge hand talker. I don't know if it's just because a lot of New Yorkers, we talk with our hands. My mom talked with her hands, so it's something that I grew up with. I try sometimes to make sure that my camera is positioned so that you don't always see my hands going a mile a minute. Um, But, sometimes, that, could be, what's the word I'm looking, distracting to somebody, right? If you're having a conversation with them. Other things, um, eye contact is a big one too. Here in American society, we recognize eye contact as a sign of respect. But in other cultures, right, eye contact is not, it's what's the word I'm looking for? It could be taken disrespectfully. It's not a common practice. So it's not, so that is something that you need to understand when working sometimes with other cultures. Another part of nonverbal communication is the tone and the inflection of our voice, right? So I can't do it, but I'm going to try. If I were to sit here and just talk to you in a very flat, monotone tone of voice, would this keep your attention? Jaquan's like, no, right? It's kind of like the anybody watched like Peanuts growing up, Snoopy, like the teacher, want, 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 want. Okay. But we do have to be careful with tone and um in our inflection as well. Some people, think that it's confidence, it's enthusiastic, but in some cultures, raising your voice, getting louder, that may mean that you're angry, okay? And so we do have to be respectful and mindful of that as well. Another big part of nonverbal communication is our appearance. And so this is something that, I've always said. It's not just our appearance, but it's our client's appearance, right? We can tell a lot just by looking about, what they, how they look, what do their clothes fit? Are they groomed? Are their clothes clean? Right? We can, see like if they have really, and they're having an exacerbation of COPD, right? They may look a little bit disheveled, right? Because they may not have the ability because of their shortness of breath to even take a shower, right? Or put clean clothes on. So we can really tell a lot from that. And clients judge us too based on our appearance too. And this is one thing that, I'm sure when you went through nursing school orientation, right? Make sure your uniforms are clean, right? That they are not overly wrinkled, right? You didn't look like you just bunched them up in a ball and threw them in the corner. And then, oh my gosh, it's time to go to class. Let me go get them out of the corner and throw them on real quick. And so how you present yourself and how you speak, they are going to make judgments about us too. If we sound really meek and shy, like we're not, don't know what we're talking about, they're going to pick up on that, right? And that could present an uncomfortable situation. The other last part of this is our effective communication. Okay. Um, Effective communication, affect is our mood, right? Or our emotion. And so that's the tone that you pick up when you approach a person, right? Have you ever gone up to someone and just been like, hey, hi, how are you doing? And they're like, fine, right? You can pick up a lot with that fine, right? Like either they don't want to be bothered, right, having this conversation with you, or maybe something's going on and they're upset, right? But we can get a lot just with that, how they respond. And it's just as significant as your verbal and your nonverbal communication. So we kind of use all of these things together when we're, looking at making sure that we are, effectively communicating with our clients, our coworkers, everybody, and all that. So other nonverbal behaviors, yawning. What does yawning tell you?
Bored.
Boredom, right? I just, and I'm going to go on with lecture. Right? It shows that I'm bored, that I don't really want to be bothered. Oh, my dog is having a little puppy nightmare behind me. Again, we talked about the arms folded, not making eye contact. Again, eye contact. Be careful with eye contact. Only because, like I said, in our society, eye contact is respectful, but other members, other cultures, they may not maintain eye contact. Looking bored or distracted. Facial expressions. This is another one that I had to work on a lot. Um, I guess sometimes I've been told that I have what's called an RBF. Okay. And so I've really had to work on that. And it's not intentional. But I used to have students tell me that I looked unapproachable, and I would be like, walking in the halls or whatever, and they would, be like, you look unapproachable. And I'm like, why? And that's when I found out. Okay. And it's not that I'm not, right? Sometimes, if I've got a lot going on in my head, I don't always pay attention to what the face is doing. So that is something that I've had to really try. And even now, like sometimes I'll go in, I'll be talking to like a patient or somebody, and they want to just tell you their whole life story. And you're trying to be as like, okay, just tell me more. And at the same time, I'm like, okay, what is my face saying right now? Like, is it saying that you can go on, or did I just, totally do a mismatch? And then your volume, like I said, the volume and the tone of your voice, that your affect, also is super important. Active listening behaviors. Okay. So active listening. So when we look at active listening, this is really paying attention. Okay. It's paying attention to whoever you're having a conversation with, whether it's a coworker, whether it's a family member, whether it's a client. And I know, trust me, I know sometimes somebody is talking to you in your head, just like you may be doing now. Oh, I got to go to the grocery store, and you're making your grocery store list in your head, or, oh, how much longer is this going to take? I really need to go finish my charting, right? It's really easy to slip into that little black hole, right? But we really need to make sure that when we are talking to a client or a family member, even a coworker, that we are giving them our 100% attention. Okay. So some of these behaviors are listed here. So restating, okay? So restating is basically just repeating what the client said in a slightly different way, okay? My foot hurts. I can't sleep at night. So what is that? How are you going to repeat that back? So, you could say your foot hurts and it's interrupting your sleep. Okay. So you've just taken that information, you've restated it back to them in just a slightly different way. Clarifying is asking a closed-ended question in response to a client's statement to be sure that you understood. Okay. So what is a closed-ended question? What's the difference between an open-ended and a closed-ended question?
Closed-ended is looking for like a yes or a no,
Hmm.
whereas open-ended is you can go on about whatever.
Exactly, right? With open-ended, we want to know, give it all to me, right? With closed-ended, we were looking for a very simple answer. Yes, no, a number sometimes, right? If I'm asking you about your pain scale. So again, it's asking questions to be sure you understand. So if, the same client says, my foot hurts, okay? So tell me exactly where does your foot hurt? So that could be they can point exactly to the part of their foot that hurts. Excuse me. Reflecting is putting into words the information you receive from the client at an effective communication level. And sometimes a lot of students, sorry, a lot of students get restating, reflecting, and even paraphrasing mixed up. Okay. But reflecting is just again, it's putting words into or putting the words into the info or putting into words the information you are receiving. And so I mean, I think the book one, I'm going to use the book one for this one. Um, if the client states, hold on, because I have to remember, I'm sick or I'm tired of seeing healthcare providers and not getting answers. Okay. So if a client said that to you and you were going to reflect on that and, give it back and tell it back to them, you're upset with the lack of answers you're receiving. Yes, LaShawn, did you have a question? No? You're
Yes, I do. I'm
oh,
sorry, I
go
couldn't get off
ahead.
mute. You see how in this one it say effective communication with an E, but on the other slide it was effective communication with an A. Is there a difference, or are you trying to say the same thing?
This one's effective. Like
So it is a difference between the two, effective and effective.
affective is your mood, your tone, how you're feeling, your affect. And then effective, like good, you're getting your point across type of, does that make sense?
Yeah.
Okay.
Okay. I just wanted to be sure of that.
Of course. And then paraphrasing, and everybody knows what paraphrasing is if you've ever written a paper, a discussion question. Okay. This is just expressing in your own words what you think they're trying, what they mean. Okay. So if they say, I feel like I'm being lied to, all right, which is, not something I often hear, but they feel like they're being, okay, so, you think that or you believe that you're not being told the truth about whatever it is. Okay, that's simple paraphrasing. Minimal encouraging, I guarantee everybody has used these at some point in their lives. These are words or sounds to encourage someone to keep talking, right? Like you're on the phone with your best friend and she's got, some tea to tell you, and you're like, yeah, yeah, come on, tell me more, right? Those minimally encouraging words, or go on, or you know, they said what, right? Like just things that are going to encourage people to keep talking. And this one is probably one of the more difficult ones. And I will tell you, this is even for me, I've been a nurse for a really long time, is remaining silent. Okay. And this is, as simple, it could just be using pauses. But the normal tendency is we want to fill the void, right? A lot of people are very uncomfortable with silence in a conversation. And so get find ways to um, get more comfortable using silence. Um, there's silence can play a huge part in a conversation for a variety of reasons. Let's say, for example, you're working with an older client, okay? And you're asking them questions. Maybe you're interviewing them, right, during their initial admission. Okay. Older people, right? Sometimes they need to take a little bit more time to process the question before they provide an answer. Okay. So you need, silence in that case will give them time to process and answer you. It could also be, if somebody has just gotten a really, a not so good diagnosis, right? And they're processing that information, right? We're not going to just keep asking and keep pushing, right? We need to give them time to process. So if you're like me, okay, it can be difficult for silence, especially, I'm not gonna lie, I have ADHD. Silence is horrible for me. Um, and so it really took a lot of practice. And then summarizing. Okay, so you're doing a client interview and that initial assessment or anytime during you're caring for your client, get a whole bunch of information, and now you're going to say it back to them. Okay, so let's say you're in a clinic, okay, and they came into the clinic, and let's say they're complaining, they say that they have 10 out of 10 pain in their foot. Maybe they had some nausea, right? Because we know sometimes people in extreme pain could develop some nausea, right? and maybe a headache. I don't know. So they've given you a whole bunch of information, okay? And now you're going to say, okay, well, Mrs. Jones, you're here today because you have 10 out of 10 pain in your, your left foot. You are also feeling nauseated, and you have a headache. Is that correct? Okay. And this is where they can say, yes, you got it. That is exactly why I'm here. Or they can say, no, maybe I got the foot wrong instead of the left foot. It's actually my right foot, not my left foot, right? So this gives them time to either, you tell them what you've heard, and then that validating allows them to either agree, say, yes, that's exactly it, or it gives them time to correct any misinformation that was heard. And we just talked about these a few minutes ago, right? The difference between open-ended and closed-ended questions, right? So open-ended, that is, going to give us more information, right? It allows the clients to respond in a way that's meaningful to them. It encourages communication, telling the full story, getting as much information as we need. Whereas those closed-ended questions require a specific answer, right? So, when did the pain start? Let's say last week, on a scale of, 1 to 10, where is your pain? A 9, right? So that gives very specific answer. For the most part, it's usually 1 or 2 words. Sometimes it can be a little bit more. Okay, but sorry. But for the most part, it's a very simple answer. Focused questions. Okay, so focused questions are going to provide even more definitive information. And so that could be, if someone comes in and says, their chest hurts. Okay, well, point to the part of your chest that hurts, or, tell me exactly where your stomach hurts. So that's even going to narrow that information down even more. Um, Other, positive communication behaviors, other things that we can do to just keep it open, and making sure that we are, keeping those lines of communication open. Be open, be honest, right? Have integrity, dependability, and use iMessages. Okay. What are iMessages? Has anybody heard iMessages before?
Yeah, that's why I
I'm
kind of.
sorry, iMessages. Like, what is an iMessage? Nobody's heard this before.
Text sounds
So
Apple
iMessages
Texter.
are they allow the receiver time to respond without becoming defensive. Okay. So instead of let's see, so let's think of another one. Um, okay, let's say you're not paying attention to me and this is really irritating. Okay. How does that make you feel if I were to say that to you? I mean, I said it to you, but I don't mean it. But how would that make you feel if I said that to you? Did it make you feel uncomfortable? Does it make you put you on the defensive?
It makes you feel defensive. Like, what do
Can
you
you
mean?
say it again? I'm sorry.
You're not paying attention to me. This is really irritating. I saw you talk, LaShawn, but you were already muted.
It makes you feel like defensive.
Right, that's going to put you on the defensive, right? Immediately. Okay. Whereas, what if I said, I feel that you guys aren't paying attention to me. What can we do to make this more interactive? How does that make it feel? How does that make you feel? Does that put you on the defensive? No, right? It means that I'm looking for feedback. Like, if I feel like you're not paying attention to me, right? The best way that I can do it is put it in an iMessage because you may be paying attention, right? And you're actively involved. So when we use iMessages, right, it takes it off the receiver, it puts it on us. It's, and this is a really good way for you to express your feelings, okay? Because, instead of saying, you make me so angry when you do this, or, and that, like I said, immediately puts somebody on the defensive, where, as you can say, I feel angry when you throw your clothes on the floor instead of throwing them in the laundry basket, right? It takes that what's the word, emotion, right? That negative emotion out of the conversation. Establishing eye contact, we've talked about that. Expressing empathy. What's the difference between empathy and sympathy?
Empathy is putting yourself in someone else's shoes.
Very good. Empathy is putting yourself in somebody else's shoes. Okay. You're able to understand, you're able to appreciate what they are feeling, but you don't feel the emotion yourself, right? So you may have a client that comes in and has had a very similar situation to maybe something that you've been through. Okay. Everybody reacts differently to different situations, or even this, a similar situation. So being empathetic, you can understand, you can appreciate how they're feeling, but you don't want to feel sorry for them. You don't want to, feel that you can't feel that emotion for them. Using, of course, open communication. Um, and self-esteem. I know this is an interesting concept to bring up here, okay? Self-esteem is earned. It is not learned, okay? You can't learn self-esteem, okay? You earn self-esteem. No one can give it to you. No one can take it away. All right. It is, when you accomplish something, when you do something, right, that makes you feel good, right? You get credit for, doing it when you do well in a quiz, when you do well in a test, right? Or even nursing school when um, you know, put in, your first Foley catheter without any issues, or right, or you get that first IV stick, right? That's self-esteem, right? Nobody can take it away from you, but nobody can give it to you either. That is something that you need to develop for yourself. And not everybody has really good self-esteem, right? There may be things in our past, right, that prevent us from having self-esteem. But I'm going to give you a little bit of self-esteem right now. Okay. Look how far you've come in nursing school. Look how far you've come, right? We're in our last class. We're getting ready to graduate. So right there and then, that is a huge accomplishment. Okay. Because I'm sure that you all can look back and know that there are people that you started nursing school that are no longer with you, right? So that right there, right? That is something that you should be proud of yourself for. Okay. So, and if you ever need a cheerleader, let me know because I will be a cheerleader for you. But think about how far you have come and how you have gotten here. Okay. So if you needed a little bit of boost today, there's your boost. Think about how far you have already come. And then, of course, being aware of your body language and your posture, right? That's always a big one. Negative communication styles. Okay. So these are things that we need to try to avoid when we're talking with people. Why questions? Okay. Because why questions can put somebody on the defensive. Okay. If they say, you're asking them about the use of nicotine, you're asking them about the use of street drugs, alcohol, whatever, and they say, yes, I use this, blah, blah, blah. Well, why do you do that? Don't you know that that's not healthy for you? Right? What is that going to do? That is going to block communication, right? They're going to be like, whoa. Okay. So we really want to avoid those why questions. Why questions? False reassurances. And I do this sometimes too, and I have to stop. And I actually did this the last night that I worked at my facility, and I had to stop. I'm like, I teach this. How could I have said that? Telling somebody it's going to be okay. Everything will be okay. Okay. And I did it. And I did it. And I was like, what is wrong with me? Because she jumped right back on me. The issue that I had, and I'll be honest with this, is it was a younger person, but she has some severe mental disability. And so she has hallucinations, delusions, and she was really upset and discussing about she thinks that, somebody had stolen all her money and they burnt her house down, which I will tell you that it did not happen. And she was screaming, and it was 3 o'clock in the morning. And I was like, okay, trying to figure out like how to get her. And I did. And she started to calm down, and I did it. I said, it's going to be okay. And she was like, how do you know? And I was like, oh my gosh, I just broke one of my own rules. Okay. So be really careful, right? We don't know it's going to be okay. No matter what the situation is, we don't always know, right? So, you have to be really mindful and not providing those false reassurances. Probing, probing is pushing for information about beyond what is medically necessary. Okay, there are some things that we don't need to know, that we don't have to keep pushing for answers. And then judging. And this, think about this, okay? This is, just like with the why questions, this is judging their behavior, okay? So, let's say you have a patient that has some, severe COPD and they're still smoking 2 packs of cigarettes a day, all right? And you in the back of your head are going, well, that's kind of why, right? Um, we don't want to judge, okay? I'm sure that if you have a patient that has severe COPD and their provider knows that they smoke, I'm sure that they've probably heard a million times, right, that they probably should quit smoking. Judging them and not, is not necessarily a good idea. We just need to provide that quality care that we're going to provide. Belittling is another one, okay? Mimicking or making fun of the clients. This is, goes without saying. It's not, you can build a rapport with the client, right? You may have like a joking rapport, but always be careful. You don't want to belittle them. Giving advice. And we know this is tempting. If a client comes to you and says, okay, what would you do if you were me? Right? Very easy to be like, well, if I were you, I would, do this. Okay. You're taking the autonomy away from your clients when you do that. Okay. So, one way would be like, I really can't tell you what I would do in this situation. What do you think would be the best options for you? Um, Somebody was saying something. Did somebody say something? No. Um, And it's the same thing too. And I don't know if this has happened to any of y'all yet. People find out that you're in nursing school and all of a sudden you know everything and people start calling you because, oh, my kid has a rash or this is going on or that's going on. What do you think it is? Right? um, avoid avoid giving advice. Um, if you give the wrong advice, if you give incorrect advice, or you give good advice and it still has a negative outcome, that could come back on you. So just avoid that. And then avoid simple answers. Okay, simple answers, like, basically is just going to, it's like you're pushing their feelings aside. You're not listening to them. You're not understanding. You're dismissing them. So always try to give as clear and can be concise answer, but give a clear answer, as much education about whatever it is as possible, so that they don't feel dismissed. Oops. And you guys know this part, right? When we look at role changes for the clients, think about it. They're coming into a healthcare setting. Maybe they're coming in through the emergency room and they just had a trauma, or it could be a doctor's office, right? Always introduce yourself. Hi, my name is Jennifer. I'm going to be your nurse today. Um, or if you're a student, hi, Mrs. Jones, my name is, I don't know, Amira, and I'm going to be your student nurse today. Again, talked about it. Don't use all that nursing jargon. I know it's fun to use sometimes, especially like you just learned it, and you want to be able to use it. You can use it around your coworkers, your peers. Avoid using it with clients. Fear of the unknown. I mean, especially think of somebody that's coming through the emergency room, they're having a medical emergency or a trauma, and we have all these providers surrounding them, all these busy moving parts, right? Tests, procedures. They may not know what's going on. They're not sleeping. They're probably NPO, right? Because we need to do tests and we don't want them to eat anything. They may be thirsty, they may be hungry. So there's a lot going on. So again, this is where knowledge is power. So tell them what's going on at each step of the way. The first, this is what we're going to do. Okay. We're not going to let you eat or drink anything, but we need to get these tests done for this reason, blah, blah, blah. You're going to have people come in and draw your blood, right? We want to just give them as much information. And personal factors. So somebody coming in, again, trauma, major life events, maybe they had a heart attack, a stroke, okay? It doesn't just affect that one person, okay? These people have families, they have jobs. What if it's, the breadwinner of the family who has just had a heart attack and now they're not going to be able to work. How are they going to support their family? So always that's where empathy and understanding is really important because it's not always just about what's going on with that person. That person has other people, right, that depend on them. And then the healthcare setting. I don't know if anybody's ever had to spend the night in the hospital or spend a couple days in a hospital. I will tell you from personal experience, it is not a fun time. Okay. The longest stay I've ever had in a hospital is 6 days. Um, and I felt like I didn't sleep for 6 days. I was uncomfortable. I couldn't get out of the bed by myself because I had had foot surgery, so I wasn't allowed to get out of bed by myself. So even if I wanted to use the restroom, wash my face, right, I had to call for help. So there's a lot of changes that occur when you are not at home in your bed doing for yourself. Talked about that. All right, S-bar. Who's heard of S-bar? Who's heard of S-bar? Everybody should have heard of it at least once, maybe. So S-bar. S-bar is a great communication technique, right? So S-bar, situation, background, assessment, recommendation. So situation, let's say you are calling a doctor because of a patient's changing condition or you have a concern, right? So first thing you're going to say is, hey, Dr. Jones, this is Jennifer. I'm on, this unit. I'm calling about Mrs. Jones in room 405. And let's say Mrs. Jones had a critical potassium level come back of, 6.2. All right. So told them who I was, where I'm calling from, the client's name, and what the problem is. Background is going to be all the other stuff. Their admitting diagnosis, when they were admitted, and then any relevant information related to that. So, I would say, what did I say? Her name was Mrs. Jones. So I could say, here's Mrs. Jones's vital signs. Here's her current medications, her allergies. Maybe she has been getting runs of potassium. Okay. And her code status. All right. So yeah, Mrs. Jones has gotten like 3 runs potassium and now her potassium is a 6.2. All right. Assessment would be what you think is going on based on the evidence. Okay. So I really think that we probably gave her a little too much potassium and that's what caused her potassium to go up. And maybe we need to give her some Kxalate, right, to bring her potassium level down. And well, actually, nope. Sorry, not ignore the KX plate. So gave her the potassium runs. Her potassium is elevated. Okay. That can potentially be life-threatening, right? Potassium level 6.2, not that's really high. And then recommendation. Okay. So I really think that we need to give her some K-oxalate, right, to bring that potassium level down. Or I really think you need to come lay eyes on the patient, or maybe we need to get a cardiologist in here to assess her. Maybe we need to send her to the ICU, right? Whatever you think your recommendation should be. Okay. Potassium of 6.2, like I said, can be really dangerous. Okay, so what do we need to do? But again, situation, who you are, where you're from, who you're calling about, and what's going on. Your background is admitting diagnosis and any information related to why you're calling. Okay, so I didn't say that we had her, maybe we had her on a continuous EKG, whatever. Okay. So you want to give them that information. Assessment is what you think is going on based on why you're calling and what the evidence that you've collected, and then what you recommend. Higher level of care, another provider. Do you need that provider to come see them? Is there a medication, something else that we need to do? The opposite side of this is the S bar for shift report. This is going to be a little bit different for shift report than it is going to be if you're talking to a provider. Okay. So with shift report, the situation is going to be because, you don't have to say, hi, my name is Jennifer. I'm calling from the unit, right? Because you're talking to a coworker. So their admission date, their chief complaint, their diagnosis, your background information, their history, their allergies, their code status. If they're in isolation, then obviously the oncoming shift needs to know that. Their lab results, their diet. Do they have any lines? So IV sites, PIC lines, Foley catheters, all of those good things, and how they move. I will tell you that is one thing that I always want to know about my clients is how they move. Are they independent? One person assist, two-person assist? Do I need to get a Hoyer lift in there to move them? So you want to give them as much information as possible. Your assessment, that's your vital signs, the pain assessment. If they're diabetic, you want to give them what their last glucose levels were, what they've had labs drawn, any studies, that kind of thing. If they're a fall risk, that's another big one, right? Of course, their medications and then recommendations. Okay, so what are the goals of care? Are there anything that, maybe I'm getting ready to leave and I didn't get a chance to, I don't know, draw labs for something, okay, right? Or, if they need to be monitored for something specific on their shift, okay, you want to let them know. And then, of course, education and discharge needs, right? Are they going to be discharged within the next 24 to 48 hours, or are they going to be here for another week or two? But SBAR, like I said, is a really, really effective way to communicate both with healthcare providers and the shift change, depending, of course. No, wait, there's no depending. What was I going to say? I just lost my train of thought. Oh, how you use the SBAR is going to be different, right? Versus who you're talking to. Um, And then communication across the lifespan, right? This is like what I was saying earlier. You're not going to talk to kids like you talk to adults. You're always going to adjust your communication and how you talk according to their age, and how much they know and understand. I worked peds for a long time. I love peds patients. Okay. One thing with peds patients, if you ever decide that you want to work with pediatric patients, get down on their level. Okay. Um, if you need to talk to a pediatric patient, sit down, crouch down, don't stand over them and talk to them. And it gets a little bit different, a little different when they become adolescents and they're taller than you and you're like, okay, this is not how it's supposed to be. Um, but adolescents generally can be the easiest group to talk to, right? Because they understand a lot more. They can communicate a lot more about what's going on with them. But just be mindful how you talk to kids. Adults, the same thing. You know, um, they may have, they're also going to be a little bit more active in the conversation, may have some more questions, things like that. And then our elderly population. Um, so the elderly population, depending on what is going on with them, communication can be easy or it can be difficult, right? If they have things like hearing impairment, dementia, cognitive decline, right? They may have some more difficulties talking with the elderly population. And sometimes it just requires us to slow down, talk a little bit slower, a little bit more clear, concise, and not, give, 100 different questions really quickly. That's where that use of silence can come in, right? Give them time to answer, I will tell you admission assessments on elderly people generally take a little bit longer than they would on somebody who is not an elderly person, just because they move slower, they talk, they may need time to process information. Not that that's all, and that's not true for every elderly person. I will say that too. But if they're sick, something is going on. That is very true. Email. Okay, so email is also a way that we are going to communicate. So first step is always to determine whether or not the email is the best way to send your message. Always think about who you're sending it to, what information that you need to send. And always use the subject line. Okay. Just a brief, like what this email is about. But don't write your whole email in the subject line. Like that's happened. Like, a lot of times if I have somebody that writes the email with all of the information in the subject line, I can't see it all. For some reason, it will cut part of it off. So be very careful with using the subject line, but always put, you know, something in there, especially, so that gives the person understanding, like, is this something I need to read right now, or is it something that can wait a little while? You can boldface, you can underline to emphasize your points. Don't, one thing too is keep your sentences and your paragraphs short. Don't send like a 10-page email, right? You want to just put the information that you need in there. Send your messages to the right person. This is embarrassing. I've done this. Go to send an email and you send the email to the wrong person, and that person's like, "What is this?" And I'm like, "Oh, hey, sorry." Um, Again, be specific. Don't throw it a whole bunch in there. Always check your spelling and your punctuation. Proofread before you hit send. Make sure that you are using full sentences, that you're capitalizing the first word, right? That you're putting punctuation at the end of your sentences. You want to make sure that you appear and sound as professional in your email writing as you would in person. And then charting. This is always a big one. Be actual, factual, do your charting timely, be thorough, but be concise. And don't use assumptions. And I'm gonna stop sharing because we're gonna take a break. But I do have to tell you, this was something that was really interesting to me. I was watching a podcast, and I'm not really sure. Now I can't remember the whole context behind it. Um, but something had happened, a client was injured, or something had happened to a client, and the they went back to the nurse that was supposed to be taking care of the client. And at the times that she supposedly did her documentation, they went through her cell phone because she was using her cell phone at work, and she was on social media. She was texting at the same time that she supposedly had done her charting and had assessed her patient. So be mindful of that. Be very careful when you do your charting. You want to make sure that it is, you're doing it at the time, that like you come in, you go in, you give medications, you do your charting right then and there. It's really important that are very accurate with what you're doing. Be very careful. I just thought that was really interesting. I don't remember the whole outcome, but I was like, oh, so, and I don't know if they had like, they didn't say anything about like cameras in the facility or anything like that, but I just thought that was an interesting piece of information. All right. So let's go ahead and take a break. Be back at 3:40. Perfect. All right. My dog is my dog is fussing at me. I don't even know what I did. All right. So chapter 9. Chapter 9 is all about assertiveness. Okay. So uh all right. So there's three major styles of communication behaviors, or there's three.
Are you going to share your screen?
I'm not. I thought I was. I am so sorry. All right, there we go. I'm gonna start sharing. Can you see it now? All right. I forgot I had stopped sharing. All right. So there's three major behavior styles when we are talking about communication. There is the non-assertive or passive, there's aggressive, and there is assertive. Okay. So we'll start with non-assertive or passive. This is fear-based behavior. It is emotionally dishonest. It is self-defeating. Okay. So a nurse who is non-assertive tends to look the other way. They avoid conflict. They just will take the easiest way out. And they never truly participate in the healthcare team. They don't express their feelings, their needs. No, 1 second. Um, okay. All right. Shahada, don't forget to add your last name, or do you need me to add it?
I can add it.
Okay. Linda, Amira, and Jamalatu, are you guys there?
Yes.
All right.
Yeah,
Amira.
Amira went to the bathroom.
Okay. All right. So again, this is, they're not going to stick up for themselves. They're not going to express their feelings, their needs, even when their rights are deliberately or even accidentally infringed on. There may be a lack of eye contact, swaying, shifting their weight from one foot to the other, complaining, even hesitancy when they're speaking, like they're not very confident when they're speaking. And basically what this is portraying that like they don't count. Their feelings, their needs or ideas, they don't count. And so with this too, they're not going to be able to recognize the needs of their clients, right? Because they can't recognize, or they're not verbalizing their own needs. They're not going to be able to recognize the needs of their clients. So, this could be, let's say they have a client that um is, I'm trying to think of word, if they're uncomfortable with a specific client for whatever reason, right? They may avoid, going into that patient's room. Or, even avoiding questions if somebody were to ask them about, a test that they have to have or a medication, right? They may tell them to, ask their healthcare provider or ask another nurse, to provide that information. So not the best way to be. Aggressive communication, on the other hand, okay, this is, it violates the rights of others, okay? And it is generally an attack on a person rather than the behavior. It's more anger based. And of course, things like leaning forward or glaring at people, raising their voice. Again, this is, a lot of times, this is like people that react, um, very quickly when someone says something that they don't like or that's inappropriate. Instead of stepping back and thinking about how to respond, right? They just kind of, in the moment, just say what they need to say. Aggressive nurses are unable to function as true advocates for their clients because they really are too worried about taking care of what they perceive to be their personal needs. And then we have our assertive. Okay. So assertiveness is another name for honesty. It is a way to live the truth from your being and to express this truth in thought, in words, as well as actions. So it's taking a positive stand, it's being confident in your statement, it's speaking openly, but in speaking openly, you're not violating another person's rights. And so this is a lot to do with confidence, right? Stand straight, face the person, maintain, eye contact. Assertiveness too is not just what you say, but how you say it. So that's where that body language is also coming into play. You want to make sure that you're speaking in a nice, clear voice. You want to speak loud enough for them to hear you, but you're not yelling at them. Um, and always speak fluently without hesitation and with assurance and confidence. And sometimes, especially as new nurses, this may be a little bit more difficult as you transition into practice, right? You may start second guessing yourselves. But, rather than, when you feel like your rights are being violated, there is a way to handle that situation, right? We don't have to be aggressive. We can be assertive and stick up for ourselves because you have the right? You absolutely have the right to express your thoughts and your feelings, especially if you feel like something is not right. And so this could even be, um, if you feel like you're getting an unfair assignment, or if you have a client that is, a little bit more difficult to deal with. Okay. Use your I statements. That also is part of being assertive in your communication. Um, if I will tell you I'll give you an example of, so way back when, as a brand new LPN, I was working on a skilled care unit, and I don't know, I had just had my son, so when I had come back to work, I was only working part-time. Um, and a provider called, and of course it was on, I don't remember, I think it was on a weekend, or I had paged the provider, my bad. I had paged the provider, of course it was on a weekend. Um, and the provider was actually on his way to the facility anyway. So he comes up to the nurse's station and he's looking through the client's chart and he starts yelling at me, okay, because he had put some orders in and the orders had not been done. Okay, so the orders were transcribed, they just weren't completed. And he started yelling at me. And I was like, um, so rather than, the old New Yorker and me jumping up and be like, I don't know who you're talking to like this. I stood up because, eye level, he was like talking over me. And I stood up and I said, okay, first of all, I don't know what you're talking about. I was not here. I am, I was just, had just come back from maternity leave. Um, and you yelling at me is not solving the situation. Please just tell me what you would like done because I'm not going to have you yell at me for something that I didn't know that I needed to do. And the first time ever, because usually he was like this with all the nurses, like he was more aggressive than he was assertive. And he stepped back and he looked at me and I looked at him and I wasn't backing down. right? I wasn't going to back down. And inside, I'm slowly dying. I just want you to know inside, I was slowly dying because I was like, oh, I'm going to get yelled at. Um, and he stopped and he looked at me and it was like that really awkward silence. And he was like, then he comes and he looks at me and he goes, you know what? You're absolutely correct. He goes, I apologize for yelling at you. And I almost fell back into my chair because he also never apologized for anything. Um, and then he proceeded to tell me what I needed to do, right? Because get the orders done or whatever. Um, but yeah, so you're allowed to stick up for yourselves, okay? Use those I statements, but be assertive. Don't be aggressive, okay? You don't want to turn it into a battle of wits, between you and another nurse, another coworker, or even a patient or a client. But you have absolutely every right to stick up for yourself, regardless of what the situation is. Coping mechanisms. Okay. So here's a good one. Coping mechanisms. How many of y'all can identify positive coping mechanisms that you use throughout maybe the day, the week, or maybe, everything is great and you only need those when certain situations arise? But give me examples, and I know this one says negative interactions, but tell me what are some examples of positive coping mechanisms?
Walking away and just taking a deep breath.
Okay, walking away, taking a deep breath. Okay, that good. Counting to 10 sometimes helps, right? What else?
I don't know. I laugh.
You laugh. Okay, you're
Hmm.
a laugher. I am too. I do too. Um, What else? What about music, taking a walk? How many of you have that one person when something happens, you immediately pick up the phone and you're like, I need to talk, right? That's a positive coping mechanism, right? You're not doing anything dangerous to yourself, right? You're finding a way to vent your feelings in a safe, controlled way. Some people like gardening. So I'm trying this gardening thing. I'm not so sure the gardening thing is going to work for me. But we're going to try it. We're going to try it. Um, what else? Exercise is a really good way as a positive coping mechanism. What are some negative coping mechanisms? What are some positive or negative coping mechanisms that people use to deal with
Because you
stress
say
or
like
Drinking.
drinking.
drinking? What else?
Yelling, using profanity,
Okay,
fighting.
drinking, yelling, profanity, smoking, illicit drugs, right? Fighting, right? Those are some negative coping mechanisms. I will tell you, I love being a nurse. I couldn't imagine doing anything else with my life. I love teaching as well. Um, where was I going with that? Oh, but nursing can be very stressful. Okay. It can be very stressful. Um, and so I will just say finding a really good coping mechanism, something that works for you, whether it is walking away, counting to 10, taking deep breaths. Some people use meditation, a variety of different coping mechanisms. You don't want to harm yourself, okay? So try to avoid the negative coping mechanisms, and really just find something that works for you. It's like I always say, I'm putting myself in timeout for a few minutes because if I don't walk away, then something might not go like I need it to go. Um, so we do have to be really careful. But other negative coping mechanisms, okay, or negative interactions, projection is one, okay? Um, and so projections are coping mechanisms where the individuals attribute their own weakness to others. Okay. And so I'm better than you, I'm more competent than you, my skills are better. Okay. This is just, and it's kind of, it is a negative, it is a negative aggressive behavior, and something that, we need to try to avoid. Rationalization is logical but untrue. Okay. It's a logical but untrue reason that is offered as an excuse for their behavior. Okay. And so this is something that, it's also non-assertive. It is an indirect behavior. And, like it could be, oh, the client just made me so mad because he wouldn't get up and he wouldn't get up and sit in his chair, for breakfast. So I yelled at him, right? Like that's rationalizing your behavior, but it's still a negative, right? Um, and denial. Denial is another one. The nurse can use this to excuse personal behaviors like, oh, I didn't know it was my job to do that. That's somebody else's, responsibility. And so it kind of, again, it's just you're using an excuse to, excuse your responsibility to do something. So again, we want to try to be assertive, not aggressive or passive, right? And so sometimes it takes a little bit of practice to be able to stick up for yourself. Other people are really good at sticking up for themselves, right? Depending on, what the situation is. But we do, I it I had to practice it. Um, because I was always one who would never stick up for myself. If somebody asked me to do it, even if it wasn't my job or it was out of, I didn't even have time to do it, but I would always be like, okay, yeah, I will. And then I end up putting myself behind. But you have to be assertive. If there's, with you, you have to know, let your needs, your voice be heard. So, problem solving. And it sounds a little bit crazy. So problem solving process is obviously it's a, a series of steps that we use to solve problems. Obviously this was, before the nursing process. The nursing process is also a very good way to solve problems. And there are a lot of similarities between the problem solving process and the nursing process. So when we look at the problem solving process, first is define the problem. Okay. Sometimes what we perceive as the problem isn't always the problem. Okay. So we have to really sit down. We have to identify what the problem is. Then we decide on a goal. Okay. So just so like you're defining your problem would be like your assessment, whatever the problem is, you're going to look at all the parts of the problem and then you're going to decide on a goal. Okay. So what do you want to do differently? And this can be as a single goal, or you may break down the goals into different parts. You can have short-term part of a goal, you can have long-term goals. It can, and of course, just like with the nursing process, these goals need to be measurable, attainable, and realistic. Sorry, attainable, measurable, and time referenced. Okay, so you kind of set you're setting a timeline for yourself to solve this problem. And, when we look at all alternatives, okay, these are your interventions. How am I going to achieve the goal that I have laid out for myself? And then you're going to try them out, right? So go through the process. And then evaluate the effectiveness. If it worked, great. If it didn't work, then you go back and you repeat the process. You look at the situation again and you just, rewrite your goals and you look at your alternatives and, you kind of, revamp those. And one of the key things here when you're dealing with something, it's okay to say, I'm not going to do anything about it. That could be one of your alternatives, right? If you go through this process of identifying a problem or a situation, and then realize that maybe it isn't that important, you can use that, I choose nothing to do about, to choose nothing to do, with it. But, of course, obviously, if it's a problem, it's something that's bothering you, that you can go through this process to try to go work it out. Manipulation. Um, so feelings and needs of others are disregarded, or other people are treated as objects to fulfill the needs of the manipulator. So dealing with a negative manipulator is difficult, and you have to be assertive. And I always say in psych, sometimes this is going to be, probably more so. But I don't know if anybody has ever come across a client while they were in clinical that was extremely manipulative. Um, and so it's always assertive, making sure you're assertive, that you're not aggressive. And aggressiveness, a lot of times with your manipulators, okay, there may be some resistance and resentment, okay, but you have to be assertive and set limits on the behaviors. And if the limits don't work, then you can absolutely stop being involved. There's always going to be a client out there that is going to be, and not always, but there's going to be clients that are going to be master manipulators. And so you have to make sure that you don't get sucked into their manipulative behaviors. Sometimes they are very easy to recognize. Sometimes they may be a little bit more subtle. Okay. But again, you with your assertiveness, okay, you need to make sure that you are dealing with those appropriately. And then other work-related issues. So again, assertiveness is super important. So aggressiveness and work-related issues. I follow a couple of different nurses. One is Nurse Erica, and I forget the other one. And both of them, they discuss issues in nursing primarily because they are both nurses. And so workplace violence, unfortunately, has increased in healthcare. Okay. So it's always existed. And of course, because of, you know, um, social media and the internet, right? It's just more well known. 10 to 11% of all workplace injuries are a result of assault. 54% of nurses experience verbal abuse by clients, and 29% experience physical abuse by clients. Okay. I feel like this has probably increased even more recently. Um, there was just an ICU nurse, and I forget where, who was gunned down by her ex at the hospital that she worked in. There was another story, and this isn't workplace violence, but I was reading another story where a nurse that was on her way to work at Maimonides in New York, was hit by an ambulance. And the ambulance didn't stop. They just kept going and left her on the side of the road, and she died from her injuries. I mean, that wasn't workplace violence, technically, okay? But there's just, always protect yourself, I guess, is where I'm trying to go with this. OSHA, which is the Occupational Safety and Health Administration, they have published guidelines to prevent workplace violence. Okay. So some of the things that OSHA recommends is like violence prevention programs, um, to try to, stop the violence, or recognize when a client is escalating, so that we can try to prevent violence. I just read another one where a security guard was shot and killed in the emergency room by a patient. Like it's really sad. um, Biggest things here is the factors that lead to workplace violence. Okay. So personal factors are your verbal, your nonverbal, your affective communication. It includes the nurse's attitudes and beliefs. Um, it is your attitude, it's your body language. So, making sure that we are approaching our clients with respect and confidence. Workplace practices. And so, again, this is where it is really important, that we provide for the safety for healthcare workers. So making sure that, the quality, the performance, and the availability of security personnel, officers convey authority, or police officers convey authority, right? Doesn't mean that they have to, carry themselves aggressively, right? They can make themselves a little bit more friendly, and security is a big part of it. Um, Environmental factors, so the type of client and the location of the care facility. This isn't something that's really important to understand as well, right? Where is the hospital located? What type of clients or clientele are going to present themselves in that facility? Are they or in the healthcare facility located in a high crime area? Right? If it's located in a high crime area, then you can kind of guess what type of clientele will be coming into there. An important risk factor at hospitals as well as psychiatric facilities, is the carrying of guns by clients, family, or even friends of clients. Okay. And then their risk diagnosis. And so, when we look at the majority of all assaults occur from a minority of people, right? It's not the majority of our clients that are coming in and performing these assaults. It's a minority of the people, right? It's a small amount of those people. And so, obviously if they have a previous history, but we wouldn't know that, right? We don't know coming into a healthcare facility if our clients have a history of, previous violence. But we also need to be able to recognize the cues, for potential risks of violence. And so some things, like some of the risks says some of your mental health disorders, if they have, chemical abuse, dementia, impulse control, personality disorders, are some potential like issues that could lead, could be part of the risk diagnosis. If you find yourself in potential danger, what do you do? I'm going to ask y'all, what do you do if you find yourself in a potential danger? What are some things that you should do?
I know a lot of jobs now have like these little silence alarms that they give you with your badge. So if you is in a like situation where your safety is at risk,
Yep,
you push the button and it'll alert the people and they'll know where you are in the building.
that's a good one. That's a really good one. What else? Has anybody ever taken a self-defense course? No.
I
What
have.
have you? Okay.
Yeah.
What about who can tell me what situational awareness is? Has anybody heard the term situational awareness?
Like looking for like clues, like being aware of your surroundings. So you like know what you ahead of the game, basically. Like you could tell what's gonna happen before it happens.
Exactly. Being aware of your surroundings at all times. Okay. Know what's going on around you. Um, you know, um, it's, just simple things. Walk with your head up, right? Don't be looking down at the ground. Walk with your head up. Look around. What is around you? What is going around you? Who's around you? sometimes we get hyper focused, right? And we're just kind of have tunnel vision. But it's not just at work, it's out in society, right? Like who's heard of I forget they have a name for it, but I don't know what it's called. Where you go to stop and get gas, right? You get out of your car to pump your gas, unless of course you're in Jersey. And they go in through your passenger door. They steal your wallet, your purse, or whatever else that you have in your car. Anybody heard that? It was going up the East Coast, right? It's situational awareness. Anytime that you feel like you're in potential danger, one of the first things you should do when you start working is always know how to get out. Know how to get out. Where are the potential exits? Have an escape route. Never ever block a door and always keep your back to the door. Okay. So if you're in a client's room, you want to have your back to the door. Okay. You don't want to block the doorway. Okay. Because if they come charging, let them go. Right. Okay. But that also, if they do start to approach you, where do you go? You can go right out that door. Um,
I got a question about that too, because still like in nursing homes, they be like, oh, you gotta shut the door when getting a patient bathed and stuff. But I rather just pull a curtain because if I'm in a room with the door closed, nobody can hear me.
right. As long as you're providing for patient privacy when you're providing care, as long as nobody coming, like walking down the hallway or walking into that room that, can see what's going on, then that's absolutely fine. You can leave the door open. Maintain open position, hands out of pockets, no crossed arms, legs. You want your hands visible. Remain calm. And that's a big thing. Okay. Sit, stand still, don't fidget. You want to be calm. You want to maintain eye contact. You want to never turn your back on the person. Okay. And I'm going to tell you, lower your voice. If they're yelling at you, lower your voice, okay? Because what tends to happen if you lower your voice, they're going to have to come down a few nodules, right? So that they can hear you. If you have the opportunity to take a self-defense course, I do. Some organizations actually will offer self-defense courses or safety training so that you can protect yourself. Um, and I hope you never have to deal with anything like this ever. Um, but early signs of workplace violence, um, unusual change in behaviors, any lack of cooperation, cursing, or other hostile forms of communication. They anger easily, frequently argumentative. They may also spread gossip or rumors, uninvited sexual remarks. They are hostile. They may also have sleep disturbances that they talk about, increased irritability and anxiety. One of the other things, too, that I have to say, and I hate to say this as well, but workplace violence is always not from a client to nurse, right? It could be from a coworker, and that has occurred as well. So, this right here, sleep disturbances, that's something, if they have sleep disturbances, I mean, some of us don't sleep very well anyway, right? But if they have these and some of those other things going on, is something that we need to pay attention to. The next stage, right? They may be like, poor me, I'm the victim. They also may start threatening notes or send threatening notes, verbalizing, a plan or a desire to harm someone, stealing property from work. They have less interest in work and assignments. They're increasing in arguments. They've also had increased physical accidents or injuries. So, prevention of workplace violence, always follow your provincial guidelines um, or preventive guidelines. Go to trainings. Some of your local police departments may offer some, what do you call it? Like self-defense type things as well. Um, Take all threats seriously. And this is one of the big ones. Take all threats seriously, even if you think it may be just a haha. Take all threats seriously, report them to management. because you don't know. You don't know if they're serious or not. And so it's always better to be safe than sorry, right? Hindsight is 2020. Let's not do that. Sexual harassment is unwanted. It is an abuse of power. It's not about sex. It's not about passion. It is about power. Um, most incidents are not reported. If you are the target of sexual harassment, the first step is you tell them this is unwanted behavior. Be very assertive. Make sure your nonverbal and your verbal communication match, and you tell them this is unwanted behavior. Okay, that is your first step, is to tell them to stop. If it continues, or you can also, once you tell that person what they're doing that is, that their behavior is offensive, it's unwanted, assertively, then of course you can you want to document for yourself what happened. And then you can report it. Employers have the responsibility to correct that behavior, whether or not you know about it or not. You may not know what the potential consequences are for that person, or you may find out, right, if they're not there anymore. Lateral violence, this is what occurs between nursing client colleagues. Um, and so, unfortunately, put a bunch of women together. Sometimes these things happen a lot. But it could be nonverbal things like eye rolling. It could be verbal. It could be withholding information. It could be infighting, backstabbing, broken confidences, scapegoating. It's sad. And then vertical violence um, occurs between persons of unequal power. So this could be the nurse to the CNA, or it could be the manager to the nurse. But the behavior is humiliating. It undermines confidence. And then, of course, the person being bullied ends up being fearful and unsafe. It is incivility in its finest form. And the last part of this is what we call insidious aggression. Incivility, aggressive behavior. Again, I'm going to stop sharing for a second. This is not to be tolerated. Everybody, I'm sure, has heard the term nurses eat their young, but this is something that we really, really need to avoid doing. If you feel like you are being bullied, if you feel like you're not being fairly treated, again, your job is to stick up for yourself and make sure that that does not happen. Um, we can't protect you once you're out of school and you're out into the workforce, but this is probably one of the biggest things that bugs me the most, with, working in healthcare, is sometimes you're going to come across nurses that are, just not nice. They're mean. Don't ever let anybody bully you, or push you around. Again, assertive, not aggressive, right? We don't want to be aggressive. We want to be assertive. All right. And then the last chapter. This is your role in the healthcare, or the interdisciplinary team. This is chapter 14 in your text. So the IDT, or the interdisciplinary care team, called it different things. It's a group of professionals, right, that all care for, a client. So depending on where you're working is going to determine who this group is. So group can be the nurse practitioner, the surgeons, the physician, um, the x-ray techs, the dietitians, the lab personnel, OT, PT, speech therapy, respiratory therapy, social worker. In long-term care, you're also going to add the activities director, because they will be part of the healthcare team as well. So again, it's all different, right? All different members. Intra, the RA instead of ER. These are healthcare workers of the same discipline that work together to integrate plan of care. Okay, so this could be like the intradisciplinary team could be, the RN, the LPN, and the CNA all working together. Okay. They're just different levels of the same discipline. We look at the different roles for nurses. So we have our registered nurse. Registered nurses education could be either ADN program, which is usually a 2-year program, like your community colleges, Fortis, or bachelor's degree, which is a 4-year program. Um, I don't know. I don't know if there are anymore, but there used to be diploma programs for registered nurses. I don't know if they still have diploma programs anymore, actually. Um, they're pretty independent in nursing, right? They can do all parts of that nursing process. Their role is in accordance with the Nurse Practice Act. They can get national certifications. Depending on what area that they are working in, there's a variety of different certifications available. The advanced practice nurse, these are like your clinical nurse specialists, your midwives, your nurse practitioners, your registered nurse anesthetist, the nurse executive, nurse educators. Generally, they are, at the master's level. Some will continue to get their doctorate. So there's a couple of different can't even say it, doctorate programs available. So there's PhDs, which are more research based. And then the DNP, or the Doctor of Nursing Practice, that is more of a practice-based. So like my doctorate, that if I ever finish, mine is in educational leadership. Okay, so DNP is the practice focus. There can be in a variety of different ones. Okay. And then we have our wonderful LPNs, right? So LPNs, it's a 12 to 18-month program, depending on where you go to school. Um, you get the fundamentals of clinical bedside care. You get, all your sciences as well. And then your role, if you practice again in accordance with that Nurse Practice Act. And generally, you're going to be under the supervision of an RN, or in some cases, a provider, depending on where you're working. So roles of RN, they plan the care, they coordinate the care, they provide care that requires more specialized knowledge and judgment just because they get a little bit more education. They also are, they teach clients, families, other members of the healthcare team, and they act as a client advocate. The LPN, of course, you're going to care for clients within your scope of practice, right? Under your Nurse Practice Act, you'll provide care in basic and client situations under the supervision of an RN, a physician, podiatrist, dentist, whichever. And you primary responsibility in the care of vulnerable populations with chronic stable conditions. So you provide safe care, you are a client advocate. You will also reinforce teaching, communicate effectively. All right. You're also going to function as a member of that healthcare team. Other things about the difference between the RN and the practical nurse. RNs can become members of the American Nurses Association at both the state and local levels. LPNs can join and be involved in the NLAPN, which is your National Association for Practical, no, I'm sorry, NA, that says L, it says F. I don't, no, I'm sorry. NALPN, that's your National Association of Licensed Practical Nurses. You also have NAPNES, which is your National Association for Practical Nurse Education and Services. These are at the state and local level as well. National Federation of Licensed Professional Nurses. So unfortunately, LPNs cannot join the American Nurses Association, but you do have your own associations that you can join. As a provider of care, RN controls decisions on staffing, controls decisions on clients' care. whereas the LPN is often a first line manager in long-term care and other community settings, and is responsible to either the physician or the RN. RN initiates all phases of the nursing process. We talked about that. They can formulate those nursing diagnoses. And then LPNs assist with all phases, and you're independent in your assessment and your implementation. RN initiates all healthcare teaching for clients. LPNs reinforce teaching. I'm not gonna go there. All right. So last part of this. Oops. So as an LPN, there is so much that is open to you that you can do as you become an LPN. Whether you decide to stay as an LPN or you continue to get your RN, BSN, MSN, DNP, NPs, or whatever it is you plan on doing. There is a lot that is open for you. More and more long-term care is opening up, and I know that's not everybody's favorite thing to do. But I have seen not just in charge nurses, I've seen LPNs as nurse managers, as assistant director of nursing in long-term care. Um, there's a lot of autonomy in nursing in long-term care as well, with the role of the LPN. But usually we'll have, at least at the minimum, you'll have a DON that's an RN. And you are going to be responsible for their care coordination. You'll also be responsible for the UAPs, like your CNAs, making sure that you give their assignments and you supervise them. You are in acute care settings. Um, there's different types of delivery. So I don't know if anybody has ever really looked. A lot of times in your ICUs, these nurses are responsible for all of the care of those clients. So they often don't have any CNAs. It is just them and their patients. Um, Functional nursing, it's basically according to task. Okay, what needs to be done. It's just task oriented. Team nursing assignments are done according to capabilities. So I know before I left Virginia, some of the hospitals there were actually going to back to this team nursing concept. So they have an RN, an LPN, and a CNA, or a patient care assistant or patient care tech, and that is the team. Okay, and each member of the team has their individual responsibilities. Case management. This is care coordination within a specified time frame using clinical pathways. So case management is a little bit different. It's really hard. I'm not going to lie. Well, you guys remember talking about case managers when you were in community nursing? They have a lot of they have a lot. They have a lot to do, especially depending on where they work, whether it's in the community or if they work for an insurance company. There is a lot that they have to do. They often have very high patient caseloads. But we always know that the patient is the center, right, of our nursing process, of our care plan, and client-centered, relationship-centered care is providing care that is respectful and responsive to individual client preferences, needs, values, and ensuring that client values guide all clinical decisions. Again, always making sure that your client is, part of that process when you are setting up that plan of care. All right. So just to follow up with some important concepts. Each member of the healthcare team provides a valuable service to the client. All members of the healthcare team are equal in importance to each other. Okay. And oftentimes you can't have one without the other. To understand where the LPN or LVN fits into the healthcare team, be aware the differences in the educational background, the role, the responsibilities, the licensing requirements. And then we talked about the definition of the patient-centered care. The last little thing here is the nursing shortage. Okay. So the nursing shortage, and I will say when I first started nursing, and I don't know if I said this in week one or not, but when I first started nursing, I heard it all the time. LPNs are going to be phased out. We're not going to have a need for LPNs. And that was almost 30 years ago. Okay. And guess what? Guess where LPNs are growing in numbers. Um, they phased LPNs out of the hospital. We're not going to ever bring them back into the hospital. They're going to be out in the community and in long-term care. And guess what? Now what are they doing? They're bringing LPNs back into the hospital. Okay. They realize the value that LPNs or LVNs have in healthcare and working in and with patients. There is a nursing shortage, and it has the potential to get worse. Um, so as the baby boomers start to retire, that's going to put a huge hole in the workforce. Nurses are getting older, they're wanting to retire. Um, there is going to, and like I said, I know this is not everybody's cup of tea, but I'm going to say it anywhere. There is going to be a huge need for nurses in long-term care, primarily because a lot of people don't want to work in long-term care. But also with those baby boomers, aging, whether the long-term care, and I'm going to say this, it's not just in a facility, okay? This is also going to be home health, right? A lot of these people are going to want to stay at home. So that's going to increase their care needs at home as well. So as LPNs going out into the workforce, you do have the ability to get that long-term care certification. Um, if you so desire. But again, so much more has opened up. My youngest daughter, she's an LPN. She started in long-term care, then she went to OB. And when she had her son, she was all she in her head, right? She was going to put her son in daycare. She was going to go back to work. And then as soon as she had him, she was like, there's no way I can go back to work. I want to stay home. So she applied, she had a few years experience already as a nurse. And so she is what is she? She's a health coach. And so, she works for a company that does, basically that is contracted by healthcare providers. And so, she follows up with them like, did they get their labs done? How are they doing with their medications, how their glucose levels, how their blood pressure is doing, any concerns that they have, then she can verbalize those in, bring those to the doctors. So she's kind of like a go-between, almost like a little bit of a case manager, but not a full case manager. So again, you have a wide variety of things that are going to be open to you as you go into practice. And you may not get your favorite job when first, but sometimes getting the foot in the door, right? Say, you start off in med surge, but there's something else that you want to do, work in med surge for a little while and then transfer within the organization to where you want to do, where you want to work, or, just see what opportunities that are available to you for growth. But a lot of organizations now, I noticed more and more too, that there are a lot of organizations, and I don't know about where, in Ohio or Pennsylvania, but a lot of places now are offering, what is it called? It's, oh shoot, where they'll pay your student loans for you. Did you guys know that? So that's
No,
an,
well, tell me about it.
I saw LaShawn was like, wait, what? What is it called? Oh, it's not tuition reimbursement. Hold on. I want to see, what is it called? I saw it I can't think of the exact verbiage right now. Um, to not, is it, maybe it is tuition reimbursement. Maybe it is tuition reimbursement. So like my oldest daughter is an RN. The hospital that she works for offers tuition reimbursement. Um, so they pay, I forget how much, but they will make monthly payments on her student loans. Um, and so of course, she has to stay with them for a certain amount of time, but she's already been with them for like 10 years. So it's like they pay a portion of her student loans, up to so much per year. I'm not exactly sure what the amount is. But then what she's doing is she's also paying at the same time. So it's like they're getting a double payment so that she can pay off her student loans faster. So look for positions that have that option as well. Like I said, some of these places, because they need nurses, they're offering more benefits. Others too have educational benefits so that once you're there, if you want to continue with your education and go get your RN, your BSN, whatever, some of them will offer, will also help you to pay. It's not going to be all of it, okay? But, some of them do offer some significant amount to try. VA hospitals also are really good for that too. The Veterans Administration, if you have a VA hospital like in your area, their benefits are phenomenal. Pay is generally a little bit higher as well. So when you're looking for your future job, and I know it's not the topic of the week, but when you're looking for your future job, look for things that, one thing that I will always say, um, and look, don't always look at what the pay is. I mean, you want to know how much you're going to get paid, but don't let that be the deciding factor. Look at what their benefits are. So, and I'll just give you a quick example. Um, when I decided that I wanted to go back to get my RN, um, I switched positions. I went from long-term care and I went into pediatrics because the pediatrics position, it was Monday through Friday. I had my evenings, I had my weekends, except when we had clinic on Saturdays. But I had my evenings, for the most part, had my evenings and my weekends free so I could do my classes and go to clinical and things. And at the time, I took about a $5 an hour pay cut. Like it was pretty significant, um, to go from the facility to the clinic. But that was, oh my gosh, let's just say a really long time ago. And even now, they still manage my 401k. Now they don't contribute anymore, okay, but they still manage my 401k. They still have my life insurance policy. I don't pay for it. That is one of the benefits of the organization. They still continue to pay for my life insurance policy. And there's other benefits there as well. That even though I haven't worked for that company for a long time, like a really long time, not just a few years, we're talking like decade. Um, that they still manage these things. So look at, some of the benefits. If it's only like $1 or two an hour difference, look at what the benefits are going to offer. And that includes your healthcare benefits because healthcare is expensive. So like the healthcare benefits at the children's hospital was a lot less expensive as well, because the organization actually paid more, so that the premiums weren't as high for the employees. So it's not always about what you're going to get paid hourly. Sometimes the benefits outweigh that just because you're still going to spend a little bit less out of pocket for some things. Just some food for thought, just something to keep in the back of your head, as you start looking. But there's so many things that you guys can do. Um, like when I was an LPN, they didn't have as many opportunities. So I look now and I'm like, this is awesome. Like I never, when I first, I did work for an insurance company for a little while. After I got my bachelor's degrees. And that was one of the requirements. You had to have a BSN, like you couldn't even just have an associate. It was like all this thing, and they would like, no, we not hire LPNs and all this stuff. And now I see all the time, where there's, case managers and help and care managers and utilization management roles for LPNs, right? So much is opening up. So nobody is going to have to worry about finding something that, they really enjoy doing. All right, I'll stop running my mouth. Um, does anybody have any questions for me? All right, well, I will post it in the announcements, but again, next Friday morning, which is week 3, so prior to class, we're going to do an exam 1 review. We'll also have an exam 1 review one Saturday morning. I will put that in the announcements so that you have it. Put it on your calendars. And like I said, Dr. Tenza usually will post either a Kahoot or she'll post a recording on there for you guys as well, to help you prepare. And if there is ever anything, that you need additional, for me as well, feel free to reach out, call, text, email. If you want extra tutoring, an extra meeting, whatever it is, please feel free to reach out to me. Don't want anybody to feel lost, or, like they're not getting what